Welcome to the Med Madness podcast, where we dive deep into the intricacies of medical conditions and their management. Today's episode focuses on ectopic pregnancy, a condition where the blastocyst implants outside the uterus, most commonly in the fallopian tubes. This topic is crucial for all healthcare professionals, especially those involved in women's health and emergency care. Ectopic pregnancy is a significant cause of maternal morbidity and can be life-threatening if not diagnosed and managed promptly. Understanding the risk factors, clinical features, and appropriate management strategies is essential to ensure the best outcomes for our patients. Next, let's discuss the risk factors and clinical features. Previous ectopic pregnancy, pelvic or tubal surgery, and pelvic inflammatory disease are among the most significant. These conditions can cause scarring or damage to the fallopian tubes, obstructing the normal migration of the blastocyst and increasing the likelihood of an ectopic implantation. Clinically, ectopic pregnancy typically presents with abdominal pain, amenorrhea, and vaginal bleeding. In cases of a ruptured ectopic pregnancy, hypovolemic shock can occur, presenting as severe abdominal pain, dizziness, and signs of internal bleeding. On physical examination, cervical motion, adnexal and/or abdominal tenderness may be noted, and a palpable adnexal mass might be present. Next, let's discuss diagnosis. When a patient presents with a positive urine hCG test, lower abdominal pain and vaginal bleeding, the first step is to assess their hemodynamic status. Hemodynamically stable patients should undergo a transvaginal ultrasound, TVUS. This imaging modality helps visualize the location of the pregnancy. If an adnexal mass is identified, the diagnosis of an ectopic pregnancy is confirmed and appropriate treatment should be initiated. In cases where TVUS reveals an intrauterine pregnancy, we manage it accordingly. However, if the ultrasound is non-diagnostic, meaning no clear intrauterine or extrauterine gestation is seen, we turn to serum β-hCG levels for further evaluation. Here, the discriminatory zone plays a crucial role. If the β-hCG level is 3,500 IUL or higher, we repeat the TVUS and β-hCG levels in 2 days. For levels below 3,500 IUL, we simply repeat the β-hCG measurement in 2 days. Now, let's move on to management. The management of ectopic pregnancy depends on the patient's hemodynamic stability. For hemodynamically stable patients, methotrexate is often the treatment of choice for unruptured ectopic pregnancies. Methotrexate is a folate antagonist that inhibits DNA synthesis in rapidly dividing cells such as trophoblasts. However, it is contraindicated in patients with immunodeficiency, breastfeeding mothers, and those with significant hepatic or renal disorders. Diagnostic dilation and curettage, D and C, is another option for stable patients with a pregnancy of unknown location. This procedure helps distinguish between ectopic pregnancy and non-viable intrauterine pregnancy. A significant drop in β-hCG levels post-D and C indicates a non-viable intrauterine pregnancy. Conversely, a persistent rise in β-hCG levels post-D and C confirms an ectopic pregnancy, necessitating further management. For hemodynamically unstable patients, immediate surgical consultation and intervention are imperative. Surgical options include laparoscopy or laparotomy, depending on the clinical scenario. It's also important to note the importance of Rhd, immunoglobulin. Rhd, negative women require prophylactic Rhd, immunoglobulin, after an ectopic pregnancy to prevent Rhd alloimmunization. This measure is crucial to avoid hemolytic disease of the newborn in future pregnancies. Cornual ectopic pregnancies where implantation occurs in the upper outer corner of the uterine fundus are particularly dangerous due to their abundant blood supply. Rupture in this area can lead to life-threatening hemorrhage. Therefore, hemodynamically unstable patients with hemoperitoneum due to a ruptured ectopic pregnancy require emergency surgical exploration. Finally, let's conclude with a real-life case study to illustrate these principles. A 28-year-old woman presented to the emergency department with severe lower abdominal pain, vaginal spotting, and dizziness. She had a history of pelvic inflammatory disease but no previous ectopic pregnancies. On arrival, she was hemodynamically unstable with low blood pressure and a rapid pulse. A positive urine hCG test indicated pregnancy. Given her instability, an immediate transvaginal ultrasound was performed, revealing free fluid in the abdomen but no intrauterine pregnancy. The clinical team quickly diagnosed a ruptured ectopic pregnancy. She was rushed to the operating room for emergency surgery, which confirmed a ruptured tubal ectopic pregnancy. The surgical team successfully removed the ectopic pregnancy and controlled the hemorrhage. Post-operatively, the patient received Rhd immunoglobulin prophylaxis because she was Rhd negative. She recovered well and was counselled on her increased risk for future ectopic pregnancies, emphasising the need for early medical evaluation in any subsequent pregnancies. In summary, ectopic pregnancy is a medical emergency requiring prompt diagnosis and appropriate management. Transvaginal ultrasound and serial β-hCG measurements are essential tools in evaluating and managing these pregnancies. For hemodynamically stable patients, methotrexate offers a non-surgical treatment option, while unstable patients require immediate surgical intervention. Always remember the importance of Rhd immunoglobulin prophylaxis in Rhd negative patients to prevent future complications. Thank you for joining us on the Med Madness podcast. Stay tuned for more insightful episodes on critical medical topics. If you found this episode helpful, please subscribe and share it with your colleagues. Until next time, stay informed and stay healthy.